Individualized wheelchair seating, improving comfort and function for older adults. This is a production of the Benedictine Institute for Long-Term Care. This video was developed by Debbie Jones, physical therapist, and Joanne Rader, registered nurse. Part 2. Conducting a basic wheelchair seating assessment is a guide for physical and occupational therapists and other professionals. This is Art, the day he was able to go fishing. He caught his limit, and I caught my passion. This is the day I realized the full impact of individualized seating. When I first met Art, he was laying in a jerry chair in the hallway. His caregivers were having difficulty positioning him for eating. Every other attempt to position him had failed because he would slide, even with restraints. But because of individualized seating, we were able to improve his function, comfort, and quality of life. In order to achieve individualized seating, it's important to understand the principles of seating. The pelvis is the key. Once you've stabilized the pelvis with a seat cushion and supported it with a back cushion, it is the anchor that provides proximal stability for distal control. In a minute, I will be demonstrating a mat assessment. It will be important to identify bony landmarks on the pelvis. These landmarks are the ASIS, which is the anterior superior iliac spines. Also the PSIS, which is the posterior superior iliac spine. You want to be aware of the sacral region, which includes the coccyx, the crest of the pelvis, and the ischial tuberosities, which are the bones that we sit on. The process of individualized seating includes the following steps. Problem identification, which includes chart review and observation of the client. Full assessment, which includes physical, functional, and environmental. Strategize solutions, which includes problem summary and objectives. Implement solutions, which includes equipment trial and re-evaluation. Let's begin with Bertie. She is an 86-year-old client who has been residing in a nursing home for several years, using a standard wheelchair with a sling back and a sling seat. In an attempt to prevent her from sliding out, she was restrained. The nurses and aides reported that she had complained of pain associated with lumbar compression fractures of her spine. She also refused activities and frequently requested to go back to bed. Our second client is Jim, who came to the nursing home in a jerry chair with a gastrostomy tube and dependent in all other activities of daily living. Finally, Lise, using a standard back sling seat wheelchair, had difficulties moving herself around and tired easily. Now that we've seen the problem identification of these three clients, we are going to follow them through the process.
Debbie, I have a patient I'd like you to take a look at. She came to us with a fractured femur and scoliosis in the back. She's in a general wheelchair and she keeps sliding down. We have her with a soft waist restraint right now, and she's not in a good position in the chair. She's causing pressure on her back and on her coccyx. She does not move herself in the wheelchair, but I would like a different kind of wheelchair if possible to keep her up so we can get her to eat by herself and increase her ADL participation as well as her socialization with the other residents.
How long does she stay in the chair?
Basically, she's in it front. She gets up in the morning, she eats all of her meals in the chair. She'll lay down after lunch for about 2 hours, and then she's back up for dinner and until she goes to bed at about 8 o'clock at night.
And how long does she maintain her position before she slides out?
About 15 minutes. I think it's just uncomfortable for her in that wheelchair.
I see.
And she has fixed contractures in her feet, so that's why she's not really mobile in the wheelchair.
Mm-hmm. And is she currently fed or somebody assist?
We're assisting her right now just because of the position in her chair. She's having a hard time getting to the plate and being able to see what's on the plate.
Is it difficult for the aides to push her around from place to place?
Yeah, because of the fixed contractures, even regular footrests don't work for her because her feet are contracted straight down. And if we don't use them, then her feet drag, and so it's really uncomfortable for her.
Is she able to attend activities?
She's not really participating in activities because of her comfort level and her position in the chair. So I was wondering if you could help me out with it.
Yeah, let's go take a look.
Okay?
It's important for me to see the person and talk to him or her in the current situation. I would look at the environment, current wheelchair, and how she's positioned in that chair. I want to get to know her and talk to the people who have the most direct contact with her. They can tell me about her behavior, comfort, function, habits, wishes, and desires, especially if she's unable to communicate with me directly. The assessment process I use has several steps. First, it's important to get Bertie on the mat to evaluate her range of motion and check for any fixed contractures. To begin with, it's important to observe the person's body for any obvious deformities. Throughout the evaluation, pay close attention to both verbal and nonverbal reactions that may indicate pain. Right after the transfer to the mat is a good time to look at their skin, inspecting the buttocks and back for wounds or redness. Okay, Bertie, let's see if you're straight. Get you straight. All right, now I'm going to lift these pillows up, and you go ahead and put your head back as far as you can, and you'll notice the contracture we have here in her thoracic area. This is fixed, and the shoulders are very tight. One's up higher than the other. As you can see here, she is unable to put her head down on the mat, which indicates a fixed contracture. Making sure her hips are straight. And the next thing I'll do is bring her legs up. Can you put your arms down at the side? Like that, good. And I'm gonna bring your hips up. You let me know if that bothers you. Is that okay, Bertie? It hurts right there? I'll be more careful. Let's put this like this. Bring her legs up again. I would just turn a little bit one side. You can see the shoulder lifting, so we've got some fixed contractures. Rotating to the other side, and she's also rotating, shoulders lifting, so we have some tightness. And if I lift her buttocks, I'm able to do some lateral, which she has a little bit of range, and it's a little bit tight. Okay. The next part I'd look at is her hip range of motion. And this is done by relaxing her leg down, holding on to her pelvis, and bringing her hip up until I feel the pelvis rocking, which is about right here. You can see her whole pelvis engaging and rocking at this point. Okay, once you find out what her hip measurement is, you want to be able to measure that. So you need to hold it into this position and get your goniometer and measure this, finding the bony landmarks that are appropriate. So after you've established the hip angle, you want to determine what her angle is at her knee. So you place your hands on the hamstring tendons and go ahead and extend her leg until you feel the tightness in the hamstrings. It's about where she's tight at this point, so I'd go ahead and measure that, knowing that's the maximum she would be able to extend her leg. After you've found the hip and the knee range, it's important to find what kind of ankle range they have. And you hold the calcaneus of their ankle to see if they've got some mobility in the ankle to accommodate a normal foot plate. And then looking on her other hip and seeing what her range is. Just about the same at the hip. A little bit more range at the knee. And then looking at her ankle with the shoes removed. holding the calcaneus again and testing for flexibility. As you can see here, there is absolutely no flexibility, and she's in a plantar flexed position, and her ankle does not have any mobility at all. So we'll need to consider, keep that in mind for our foot plate selection. The first thing you want to do after you've sat them up from the supine part of the mat assessment is to make sure that their feet are well accommodated by placing them on a board or something that gives you the proper height so they have the right mat, they're sitting on the table correctly. And as you remember, this foot didn't have a lot of problems, so she can put this one nice and flat, whereas her right foot had a contracture that we're just accommodating by placing it kind of on the edge right now. Had I placed it up on the board, then her knee would go up higher and show some differences or some changes in her pelvis. So you want to make sure that you're accommodating for some of the problems that you found in the supine part of the mat evaluation. Okay, now that Bertie's sitting up, can you sit up as tall as you can, Bertie? Okay, you can see she's got good trunk control, but it's real obvious now, the curvature of her spine. Following her spinal column down, you can see that there is a slight curve as the path takes place. She has a rib hump in that this rib is a little higher than this one. Okay, and she's got good trunk control and strength to stay up, but she's unable to sit completely up because she does have this fixed contracture in the forward head. Bertie, can you lift your head up on your own as high as you can take it? As high as you can go. Okay. And I'd look at her hips and see if her pelvis is level. Making sure her pelvis is not rotated, which it is slightly, and I can see if just readjusting helps that. And she seems like she's in a good position. When I put up my hands on her pelvis, I can bring her pelvis into more of a neutral position, but then her head comes forward and falls down. But if I relax on her pelvis and ask her to hold her head up, can you hold your head up, Bertie? Real tall. And you can see if she has some pelvic support. Too much support brings her too far forward. Giving her a place to relax helps. Bertie, can you lean back? There, and stop. Okay, that's good. What we're looking for is level eye gaze. Can you hold your head up, Bertie? Right there. So we look at these curves and try to make a decision on what kind of back shape would work best for her. Bertie's problems include a fixed thoracic kyphotic spine, a posterior pelvic tilt, limited hip flexion, and a right foot contracture. The seating strategies for Bertie are to accommodate for her fixed contractures, protect her skin, and support the pelvis to decrease pressure on the lumbar spine and prevent sliding. Her solutions would be that she needs a back cushion that matches her back curves, one that supports the back of her pelvis and permits level eye gaze. A reclining wheelchair would not be appropriate because it would not support her pelvis. She needs a contoured seat cushion to accommodate her pelvis, to support her thighs, and a foot plate that's adjustable to the angle of her right foot. A wedge cushion would not be appropriate because of her limited hip range of motion.